In 2023, a woman in Texas went to the emergency room with a headache. Doctors determined it wasn't serious, gave her a Tylenol, and discharged her. The bill was $6,208. The Tylenol line item was $48. The same 2 pills cost 2 cents at a Walmart 5 blocks away. She didn't have an unusual experience. She had the standard American healthcare experience, and the $48 Tylenol isn't a pricing error. It's the logical endpoint of a system that has deliberately divorced prices from costs over a 60-year period. To understand the $48 Tylenol, you have to understand something called the chargemaster. Every hospital in America maintains a master price list containing every item and service it provides. There are roughly 50,000 line items in a typical chargemaster, from aspirin to open-heart surgery. The prices in the chargemaster are not based on what anything costs. They're not based on what any insurance company actually pays. They are, in the words of one hospital CFO, a work of fiction that everyone agrees to pretend is real because it serves as the starting point for negotiations that no patient is ever involved in. The chargemaster exists because of how hospital billing works. When you receive care, the hospital sends a bill to your insurance company based on chargemaster prices. The insurance company responds with a contracted rate that is usually 40 to 80% lower than the chargemaster price. The difference between the chargemaster price and the contracted rate is called the contractual adjustment, and it's written off as if it were a real discount. If you don't have insurance, or if you go out of network, you're billed the chargemaster price directly. You're expected to pay the number that was never intended to be paid by anyone. The $48 Tylenol exists because the hospital needs a starting number high enough that after the insurance company applies its 60% discount, the remaining amount still covers the hospital's actual costs plus a margin. The margin math works like this. The Tylenol itself costs 2 cents. The nurse who administers it costs about $40 per hour, and giving someone 2 Tylenol tablets takes maybe 2 minutes, so $1.33 in labor. The pharmacy that dispensed it, the computer system that tracked it, the liability insurance that covers the hospital, and the administrative staff that processes the billing all add overhead. The actual cost is probably $5 to $10. At a chargemaster price of $48, even after a 60% insurance discount, the hospital collects around $19, a 100 to 300% markup on cost. That's the business model. This model wouldn't work in any other industry because customers would revolt. It works in healthcare because of 3 specific market failures. The first is that patients don't shop for healthcare. When you're having a heart attack, you're not comparing ambulance prices. The demand for emergency care is perfectly inelastic. The second is that information asymmetry is extreme. You don't know what treatments you need, whether alternatives exist, or what those alternatives should cost. You don't even know what questions to ask. The third is that third-party payment severs the connection between consumption and payment. When someone else is paying, neither the patient nor the provider has any incentive to control costs. These 3 failures compound. Because patients don't shop, hospitals don't compete on price. Because hospitals don't compete on price, prices have no relationship to costs. Because prices have no relationship to costs, insurance companies negotiate discounts off chargemaster prices rather than reasonable rates. Because the chargemaster is the reference point, hospitals have every incentive to inflate it. Every year, each hospital multiplies every price by 1.05 or 1.10, because the starting number only matters relative to the discount it will receive, and a higher starting number means a higher number after the discount. This is how a $5 procedure becomes a $50 charge over a decade, not through conspiracy but through the compounding of a fundamentally broken reference price. The federal government has attempted to fix this twice. In 2019, the Trump administration issued an executive order requiring hospitals to publish their chargemaster prices online. Hospitals complied by posting spreadsheets containing 50,000 line items with incomprehensible medical codes in formats that were technically machine-readable but practically human-unreadable. In 2021, the requirement expanded to include negotiated rates with insurance companies. Compliance has been spotty. A 2023 study by Patient Rights Advocate found that only 36% of hospitals were fully compliant with price transparency rules, and many of the compliant hospitals had published data that was internally contradictory or impossible to compare across institutions. The fundamental problem is that price transparency assumes patients will shop for healthcare, and they won't, because healthcare is not a shopping experience. This brings us back to the woman in Texas with the $6,208 headache. Her bill included the $48 Tylenol, a $3,200 CT scan, a $1,800 emergency room facility fee, and several $100s in miscellaneous lab tests. Her insurance company negotiated all of it down to about $2,100. She was responsible for a $500 deductible. The hospital collected $2,100 for care that, in any rational pricing system, should have cost $400 to $600. The system works exactly as designed. It just wasn't designed for the patient.